Okay, I am back and I am screen sharing still. So I'm going to go back to my screen. There we go. Okay, so, all right, we talked about this already. Culturally, we know that we have to be aware of how cultures view and express anger. And then we've already talked about the health disparities. Some culture-bound syndromes involve anger, suppression, or aggressive behavior. I recognize the last one, running amok. So I'm sure you've all heard that one. The other two I'm unfamiliar with, but they're probably in your book. I'm not going to ask any questions over them. Just be aware you need to be culturally sensitive. Treatments. Treatment is to focus on the underlying psychiatric diagnosis. So again, this is the related disorders. So we can use lithium, carbazepine, typical, atypical antipsychotics, benzodiazepines. Haldol is a traditional antipsychotic or neuroleptic, and lorazepam to help decrease anger and aggression with psychosis. So most effective, least restrictive. So one-on-one distraction, putting them into something else to help um, change the way they're looking at cognitive behavioral therapies, or some sort of seclusion or restraint when somebody becomes um, angry and aggressive and hostile, because you have to protect other patients from themselves. How do we manage it during the triggering phase? You guys need to be aware and watch for escalation. And I'm sure you've seen escalation in your various places where you currently work. So when they're in that triggering phase leading into escalation, we want to kind of nip it in the bud. We want to be empathetic with them, sit down and talk with them. Very short, concrete statements. Tell me what's making you angry is a good one to go. Allow them the time to tell you what they need to tell you, getting them out of that hustle and bustle of wherever they are to a more quiet area. And then, of course, you can always offer PRN medications if needed, or, something physical if they're capable of going down, going to the gift shop, going for a walk. Um, Even if you go walk with them or something, that's going to help with the behaviors. Aggressive behavior. Again, this is the escalation phase, the triggering and escalation phase. You have to get control of it once they have reached that escalation and they're almost at crisis. Very calm, very firm, giving that direction that they need, some boundaries that they need. Let them know that aggressive behavior is unacceptable. Again, with a medication to help calm them down. And then sometimes if they reach that crisis point, there's really a fine line between escalation and crisis, but you'll know it when you see it. You do the show of force. Show of support is what we call it at Mercy, where they call it overhead, and people come from their behavioral health team to help calm the patients down. Aggression, the crisis phase, you got to get charge of the situation right away for safety reasons. And this is either restraint or it's going to be physical, chemical, seclusion. This is where that comes in here. There is special training for psychiatric nurses, NAPI training. You don't get that unless you go to psych. It's I don't want to go too much into it because I really want to know details about it, but it is used as a first line for handling crisis phases. And then the recovery, you need to talk to the patient. What helped trigger them? What tripped them up that led them down this road for anger and aggression? And then, of course, document everything. If it wasn't written down, it wasn't done. So you need to document it. Debrief the patient, debrief the staff. Very important that the patient and the staff talk about their feelings related to the situation. And then post-crisis, when the patient has calmed down, they can come out of their seclusion, they can come out of their restraints, And then you guys can sit down and talk like adults as to what brought them to the crisis situation. And then help them figure out other ways when they recognize themselves escalating that they can do other things they can do to calm themselves down so that we don't have another outburst. And then evaluation. So care is most effective when anger is diffused. So if you get them when they're triggered and you talk them down, or they talk themselves down and you listen, then it's a win-win for everybody. So your goal is to teach angry, hostility, potential aggressive clients to express themselves verbally without threats, without assault on other people or their property. Workplace hostility. I know we've talked about sentinel events for intimidation and disruptive behaviors. Those are out there. Bullying, workplace bullying, can be really troubling, but this could also be verbal abuse by patients. We, as nurses, have always been ones that sidestep that, using those passive activities with them, not really engaging with patients. If a patient is coming at you, they could be outright angry, throwing things at you, screaming at you, or they could refuse to do things that you want them to do. They could be uncooperative. When you're dealing with staff to staff, this is called insubordination. When you're dealing with this with patients, it is a passive way they can be aggressive. So it's just not, it's something that's ugly in the workplace. And as professional nurses, we don't want to have that between nurse to nurse. We can't help what's happening with patients because they have a right to be who they are, but with each other, we need to have a little more respect. Um, okay, so in the workplace, it's good to have that code of conduct so you can reference back to that for what's acceptable and unacceptable behaviors amongst yourselves. Process for managing unacceptable behavior with other staff, and then expectation of professional behavior. So zero tolerance. This is what's really needed in the workplace for nurse to nurse hostility and anger is zero tolerance. And then community-based care. So we go back to our patients who are angry. We want to make sure that they are compliant with their medications, are coming to all their follow-up appointments. But there's always the potential that you're going to be assaulted by a patient. And then just be aware of your own management anger. I'm pretty passive myself, but I've been a nurse for 30 years. So, it's just ingrained. I don't really not really a fighter. So with patients, very calm about that. And I had to learn very early not to get upset with bullying from other nurses when I was a young nurse. I had to learn not to get upset by that. That was very challenging. You guys have probably experienced this already in your workplace and you've adapted. So just know yourself. Okay. Okay. I'm going to stop that. And we're going to go over into 12. Yeah, abuse and violence. I think I'm still screen sharing, which is good. From the beginning. Okay. Now I'm going to shrink this. I'm going to close this. Oh, stop and show. I'm going to go back to this. Hello. And make sure I'm still screen sharing because I screwed this up already once, so I don't want to screw it up again. That's 13. That's 12. Okay. Share. Okay, now screen sharing again for abuse and violence from the beginning. So, abuse and violence. I know we talked about this in class. Some definitions: abuse being the wrongful use and maltreatment of another. Perpetrator is usually somebody they know. It can be children to the elderly to your spouse. There are lots of different kinds of potential injuries, physiological, psychological, and survivors really have a lot of problems or could have a lot of problems. Characteristics of violent families could be battering, neglect, but the common characteristics are usually the families are socially isolated. There's one person who's in control, and they are usually the one who uses drugs and alcohol. And this is something that it's intergenerational, which means if mom and dad are abusive, then children probably will become abusive adults. Culturally, we have to think about abuse related to different cultures, but it doesn't matter. It's abuse is abuse. Um, Battered immigrant women, those are the ones at higher risk, especially those who don't know the language. So if you have someone who English is not their first language, it's your patient you're taking care of, and you have a spouse or partner who's hovering all the time, and you really know you're not supposed to take history or anything from them, but they're the ones explaining what's going on. It's probably a good idea to get a translator on board. Intimate partner violence. This is mistreatment or misuse of one person by another in the context of an emotional, intimate relationship. Usually it's some sort of psychological abuse, emotional abuse. It can be overt, such as physical abuse, sexual abuse, or it could be um, psychological, by, just basically belittling them, and neglecting them, giving the silent treatment for days, things like that. Rates for victims are usually women and they're higher, and the incidence of pregnancy actually goes right along with increases in abuse for these women. However, domestic violence does help them in same-sex relationships at exactly the same frequency as in male-female relationships. Okay. Into a partner two, I'm going to say, heterosexual relationships. Abuse is usually husband against wife. They look at the wife as a possession. But this could also be for children. Children are going to be considered possessions that the person who's abusing them can do whatever they want to with them because they own them. Um, the abuser usually has a low self-esteem and low problem solving, and his way of solving problems is through abuse and control. Um, Whenever the children become more independent or the wife becomes more independent, you're going to see an increase in violence. Sometimes they break bones at this part, sometimes they commit murder. Um, when women are accepting of the abuse, they tend to pick up the dependent personality type, dependency trait, um, which we'll talk about that when we get to personalities. The cycle of violence starts with a violent episode. Then, of course, you've seen it all in the movies. Oh, I'll never do that again. They buy flowers and candy and whatever. But then after that, the tension continues to creep up until there's another outburst. Um, in assessment, you're not going to see abuse victims. They'll have a restricted affect, but you're not really going to see them coming to you to talk about the abuse in the hospitals. They're going to be coming to deal with physical complaints. They broke their arm falling down the stairs, or they hurt their ribs because they took a tumble or something like that. Um, you should, and I believe at most places around here, one of the first things you assess is, do you feel safe at home? So that's one of the questions, the big questions you're going to ask. Do you feel safe at home? There is, or there are laws, including restraints or protection orders, for domestic violence. A lot of people think that's, not effective, probably. We do have legislation for stalking now where you can put somebody away, if they are, actually pursuing you. Um, uh, showing up where you're at. They just you guys know what stalking is. So there is now laws for stalking. There are shelters that people can go to, not a lot around here for women and children, but in the bigger cities there are. For people who are abused, individual counseling should come first and then group therapy. And then, of course, if they have PTSD, treatment for that. Child abuse, the intentional abuse of a child. Or, like I said, it could be emotional too, so neglect or failure to prevent harm. Um, Abandonment, sexual assault, and then just torture. Clinical picture of the parents, and this is when we get talking about children's psych, this is something you're going to see. The overreaching idea for parents in abuse situations or in child psych situations is that the parent doesn't have the right knowledge base to take care of the children. So we need to teach them how to best take care of their children. They're not your property. We can help you if you need respite, something along those lines. CPS will talk to you or talk to the parent like that. The idea is not to break the family up. You guys are mandated reporters. You do need to report any suspicion of abuse. You don't have to know it's abuse for sure. It's for the child's safety and well-being. Once there has been a case filed, usually they come in, CPS will come in, they'll do a home visit, they'll talk to the children. Sometimes if it's multiple reports, they'll put them into therapy. But it really depends on the age of the child. Children use a lot of play therapy because they don't have language skills to get out what they need to say. So if that is the case, individual therapy and then family therapy, because again, they don't want to take families apart unless it's absolutely positively necessary. Elder abuse on the other end of the spectrum is kind of like child abuse, could be physical, could be sexual, could be financial. That's a big one for elder adults. Estimated 10% of the population over age 65 are abused by caregivers. People who abuse older adults are almost always the caregiver. And I'm not saying children, I'm not saying spouses, although those guys are caregivers and they are abusers. But aides and nurses, things like that, can happen. There is bullying that happens in senior nursing facilities. It's kind of like the kid on the block, give me your lunch money. Well, this person may like your blanket. And they say, give me that blanket. And, they may threaten you to get the blanket. So it just depends on the type of abuse. Assessment, treatment, intervention. Again, we talked about caregiver stress relief, resources, and then if we need to, removal of the older adult from the abusive situation or a change in the caregiver. Rape. Rape is abusive. Perpetration of an act of sexual intercourse on a person against their will or without their consent. Age of consent in Ohio is 16. And sometimes it's done by force, fear of force, drugs or intoxicants, so alcohol. It's a crime of violence, and it's also rape if the victim cannot exercise rational judgment. So 13 kids, and you don't need full penetration. It can be committed by strangers, acquaintances, married people, people of the same sex. We have date rape. That's one of the top ones that is out there. These days, they use Benadryl in high doses to incapacitate their victim. Oh, I'm sorry. Highly underreported and most commonly around the victim's home. Most rapes are premeditated, which means they know they're going to do it before they get there. And then male rape is highly unreported. Generally, rape is not a sexual crime. So it's not about the sex, it's about the power and the control. So it was thought for a long time that women were objects of aggression. So women just automatically would be attacked because, I don't know, they were objects of aggression. It's a feminist theory. I don't know that that is the case these days. I think that just about anybody could become a potential victim. The motivation of the victim is to stay alive. So if that is doing what you need to do to maintain your life, that's what you do. But it is pretty severe in the trauma. There's a lot of myths. The big one being, what was she wearing? That's a myth. Doesn't matter what you're wearing. No is no. Assessment, we do want to have the physical examination, description of what happened. We can do rape kits. Usually it's the sexual assault nurse examiner who does that, or the same nurse or the ER physician, which you would assist with. And then immediately you want to offer emotional support. Give control back to the victim. You're going to treat or assist in the treatment of prophylaxis for AIDS, pregnancy, and other STIs or STDs. Counseling, one-on-one. That's first. Group counseling can come later. Community violence, we do see school violence. That's terrible these days. Kids coming in with shotguns into schools and killing other kids. They're doing it on college campuses too. Bullying in the community, hazing, you see this sometimes in sororities, fraternities, sometimes different clubs and such. It has a huge, huge impact on the way our kids, um, well, just about anybody reacts to society at large. Because remember, society tells us what's normal and what's mentally healthy, versus what's aberrant. And of course, we have terrorism, which can lead to a lot of issues. I know my daughter, she has PTSD. And when Trump bombed Iran, she was on the phone with me in a panic because she thought for sure that it was going to just come back on us, et cetera, et cetera. So those type of situations, they're very hard for younger people to understand how much of an impact it can have on them. If you don't feel like your world is going to be around for much longer, you might be depressed. Why live? Because nobody else is going to be, that kind of thing. So we just have to be aware as providers or as nurses, how to deal with children or people's perception of violence on a global scale and help them understand. And then you got to be aware of yourself. How do you feel about it? What triggers you? What causes you to take pause? I struggle with abuse, domestic violence. I struggle with domestic violence. I don't think, well, I know I can't deal with this kind of a situation. People who pick on old people and children, just I can't deal with them. I can't deal with them. So I'm not equipped that way. But you may be, which is good. And because we need people like you, if you are, then hop right in there and do what you need to do. Okay. All right. So we're going to stop the share. And we're going to go back and we're going to catch 13. And I know we didn't talk about 13. Okay, I'll bring that up there. And we go, wait a minute. No, I'm doing wrong. Now we go back here. Okay, good. And now we want to share. Oh, share. And we want to share 13. This is 13. Yep, this is 13. Okay, and we should share. I'm gonna get this right, guys. I swear to goodness. I'm gonna get this right. And I want to do this and this. All right. Trauma and stress related disorders. Okay, slideshow from the beginning. Why is that paused? I want to pause it. All right, we're gonna do this. I spoke too soon, didn't I? Okay, I'm gonna stop the share. I'm gonna try this again. Hang on. Now we're gonna share it. Oh, good. Okay, there we go. Okay. Haha. Okay. I hope I'm screen sharing and not just laughing and acting stupid. So says I'm screen sharing. So all right. So trauma and stress related disorder. Trauma and stress related disorders are ugly. Um, they happen and we gotta learn to deal with it. So oof, okay, back. People experience trauma and stress when we have stressors that are beyond daily life. Okay. Examples, abuse or illness, and then group trauma and stress, war, natural disasters, terrorist attacks, things like that is for group stress. Characteristics, all persons experience anxiety, insomnia, difficulty coping. Most work through it though and get through coping. Some individuals could get um, issue and problem in managing it, and they may develop adjustment disorders, acute stress disorder, PTSD, or dissociative disorders. And these are all individual disease processes that you may encounter that people are not coping with their stress and trauma effectively. So they develop this as a coping mechanism. Okay. PTSD, disturbing pattern of behavior demonstrated by someone who has experienced a traumatic event. Again, we have the individuals and we also have the group. It could be posted actual or threatened event or a serious injury. So some responses, intense fear, helplessness. I hear the word terror a lot. There's some subcategories of symptoms. They may re-experience the trauma in dreams or recurrent and intrusive thought. So maybe they're in war, they went to the Gulf in that war, and then they come back and they have lucid dreams about being in the war, or they have recurrent thoughts that there are spies amongst us or something like that. They avoid situations, coping situations. They have negative thoughts, and they're usually very hyper aroused or on guard. That's another way of looking at it. The related disorders with this one, adjustment disorder. Symptoms develop within a month, but last no more than 6 months. It's some sort of reaction to a stressful event that causes problems for the person for coping. Acute stress, this is again re-experiencing the trauma, avoiding situations regarding the trauma, being hyper arousal. It is the precursor to PTSD. Occurs 3 to 4 times a week after the trauma. And then we have reactive attachment disorder or disinhibited social engagement disorder. Those are the traumatic experiences for those younger than 5. Etiology of PTSD, there has to be a causative trauma associated with event exposure rather than personal characteristics. So to be PTSD, they were at the war, but they didn't lose a limb. Okay. They usually have a lack of social support. They may have, during the trauma, they may have disassociation. Sometimes the personality can increase the risk. So if they're more of a dependent personality type, they're more likely to suffer from PTSD. It just depends on the person's coping and the level of trauma that they're experiencing. So adolescents are more likely to experience PTSD than children or adults. Increased incidence related to age, gender, type of trauma, and repeated trauma. Adolescents suffering from PTSD may have increased risk of suicide. Substance abuse, they may have problems with social features, academic problems. They may not take care of themselves and have poor physical health. When somebody is recovered from PTSD, you see all of this uh, after adolescence. Say an adult, they've been through this during adolescence. As an adult, excuse me, as an adult, they're going to recover from this, and you're going to see the complete opposite of this. You're going to have they've reached out and established better support systems. If they're coming back to school, their grades are going to be much higher. They take care of themselves. Those are survivors. That's kind of how we have to look at this. For rape victims, we don't want to see them as victims anymore. We don't want them to see themselves as victims anymore. We want everybody to be on the same page, and they are survivors. Now, cultural PTSD is universal. So some people have political oppression that causes their PTSD. When they have a strong sense of community, there's less PTSD and better long-term outcomes. PTSD treatment, counseling, usually individual first, such as in rape victims, and then you can go into groups. Medications, most medications we give people are to treat specific symptoms. So if they are insomnia, we'll give them something for sleep. Example, cognitive behavioral therapy, again, is a good one. You look at a situation, change the way you think about it. We have exposure therapy. That's kind of a rough one. It's kind of like flooding. You're completely exposed to the situation that you experienced. And sometimes it's hypnotherapy. They walk you back through that situation, and then they use the cognitive behavioral therapy in it. How can you look at the situation differently? How can we process this differently? Relaxation techniques. One of the big thing that lots of people do in relaxation techniques is the breathing. You go in for 2 or 3, you come out for 4 or 5, and you keep it really slow and intentional. And then you tell whoever you're talking with, you relax different parts of your body at different times. It's very effective. Adaptive disclosure. So you talk about how you changed. What did you do differently after you were raped? Did you try jogging in a different path? Because that would be healthy. Or did you stay at home and kind of self-isolate and didn't get out of the house? That's really not healthy. So what the adaptive disclosure is, and we treat them through processing or cognitive processing, helping them determine what's the best for them as far as getting back to a life post-trauma. Okay, so that's a lot of mental health promotion. There is a lot of community-based care that's out there. I think that's more for global trauma, like if we would get bombed or something like that. You see more communities coming together versus the individuals experiencing trauma. I needed that one-on-one. Oh boy, I told you it's been a long day. One-on-one experience. Dissociation is really interesting. It's a defense mechanism used to prevent recognition of the event that can occur during or after the event. Sometimes you just slide into it. Um, it can be sudden, sometimes it's gradual, but usually there's some sort of disruption in consciousness, memory, identity, or environmental perception. So these people are outside their body, looking down, seeing what's happening, or they become a different person, personality, or hang on there. These are all of dissociative disorders. We do have disassociation can interfere with relationships and ADLs and the ability to cope. So if you're always going off on a daydream and always not dealing with what's right in front of you because it's easy to slip into that as a coping mechanism, you really just can't get through life. They're seen in people with PTSD. The big ones, dissociative amnesia, this dissociative identity, that's the multiple personality, and then depersonalization or derealization are dissociative disorders that can happen in PTSD. For dissociative disorders, individual therapies, and then group therapies. I think you're kind of picking up the trend there, individual first, then group, and then medications for anxiety or depression or both. We want these people who disassociate too easily to not do that to improve their quality of life and how they can function. Like I said, it's really easy to slip into that coping. I'm not going to deal with this situation. I'm just not going to. And you see yourself, driving down the road and you know that you are white knuckled because traffic is terrible and you're going 70 miles an hour and the person's big semi behind you is going 95 and you were in a car accident not that long ago and oh my God, that's the disassociation. Okay. Um, Assessment. It's not necessary for a client to detail the trauma or abuse. We want them to talk about how they are coping with that. We'll pick it up. We'll just see them. They're hypervigilant. They usually don't like people to get really close to them. They might be anxious or be hostile or agitated. If you tend to be one of those people that goes in further than that 3 to 6 feet, their mood for PTSD can be passive to angry. It's very labile. Their thoughts, they're going to tell you, PTSD, they're going to tell you it's either flashbacks or dreams. Those are the two. And when they say dreams, nightmares, that's what it is. They want to kill themselves. There may be, I've not seen one that has fantasies, but I imagine there might be something where they have a lot of wish therapy or not wish therapy, wish thoughts. I wish this would have never happened and this would be the life if that hadn't happened. Sometimes there's orientation to reality during the flashback, but that's not often. They go back, they're there, they're in it. Sometimes there's memory gaps because you don't remember your trauma or abuse. Or if you do, all you remember about it is that you want to kill yourself. Other assessments. Hang on. Judgment. This is where we give them that situation, say, what would you do? So decision making definitely can be impaired. It may be, you have a flat tire at 2 a.m. in the middle of Lima. What are you going to do? Well, I take cover because, I'm going to be shot out by the enemy. They really will not see a relationship between the trauma and the way they cope. They might have a low self-esteem, see themselves as worthless, or they might have some real problems with people of authority. They have trouble sleeping, eating, and illicit substances. So we need to talk to them about self-harm. We don't want them to self-harm. We don't want them to hurt anybody else. Same assessment. help them with a plan for going to a safe place. They calm themselves down. Use grounding. Grounding is wonderful. Grounding is, what do you see? What do you hear? What do you feel? What do you smell? So you're bringing all their senses back into them because they're not experiencing any of it when they're in a disassociative state. So you're bringing all them senses back into them. And do you feel the floor beneath your feet? Do you smell the flowers? Do you hear the traffic? And once you get all that back, that grounding back to them, that reality, they become more cognizant of the reality. Supportive touch, I don't recommend it right off the bat. Textbook does. I would probably wait until you have a better, more in-depth therapeutic relationship with them, but you can do the relaxation techniques, the deep breathing. You can use distraction and then calling them survivors. Okay. There's or grounding techniques. Remind the person they're in the present, they're safe, you're here, you're safe, I'm with you, you are an adult, you're not a child. Tell me what you're experiencing, what you hear, and keep the client in the present with you. And then be aware of your own stuff. How do you deal with PTSD, or how do you deal with traumatic events, natural disasters, things like that? Remain non-judgmental and be as empathetic as possible. Okay, I think that's it. That's 11, 12, and 13. Please, please, please look at the questions again on the poll everywhere. And we'll start with the quiz tomorrow, and then we'll move into 14, 15, and 16. Talk to you tomorrow. Bye.